Hello, everybody, and welcome to day 2 of the Wage Spring 21 conference. I'm really sorry we're a few minutes late starting, but we're continuing with the theme of yesterday and still having some technical issues. But hopefully we've got it sorted now, and we've got some really interesting sessions lined up for you today. So the aim of this sort of Tuesday session really was to obviously to learn about the new developments that are happening across the UK at the moment that will be really relevant to us as we recover from the pandemic, but also to launch some monthly learning events that we are going to be supporting through Wage. So we've listened to feedback from members who have asked for more sort of opportunities to learn and have update sessions. And there's some really successful trainee sessions that are currently running from Cardiff on a Tuesday evening, and they very kindly agreed to let us join them for one session a month. So this is the first, but we are aiming to repeat this on the first Tuesday of every month for the next 12 months. So we've pulled together a framework which has many different topics which we're hoping will be of interest to all of our members. But if anybody has any other topic suggestions, it'd be great if you could let us know. And after today's session, we'll be circulating the 12-month programme, and so you'll know what's coming up at what stage. Hopefully you'll find that really interesting. But for today, we are going to learn about some new developments, and I'll start off by introducing Dr. Sunil Jalwani, who I'm sure needs no introduction at all. But he's going to talk to us about the FIT framework for Wales, which has been developed. Sunil, as you know, is the clinical lead for the Clinical Pathways workstream of the National Endoscopy Programme, and the FIT framework has been launched recently. So it'll be helpful to have an update on where we are with that. So thank you, Sunil.
Thank you for inviting me to speak on the topic of the FIT framework for Wales. And I'll try and attempt to give a brief overview of this in the time we have. So to launch into it, the principles of implementing FIT were that there should be quality assurance in the lab. And quite important to understand right at the outset that it is only meant in this framework to be used as a risk stratification tool and as part of a comprehensive patient assessment for the investigation of patients with suspected lower GI symptoms of cancer, and not as a diagnostic test. And this is an important difference. It's also important that there is good communication between patients and clinical teams regarding how a FIT-based management looks like, both in primary and secondary care. And this is only possible if we've got robust safety netting mechanisms in place. Regardless of the FIT result, clinical decision-making and prioritization, including of alarm symptoms, should not be ignored. And we can miss cancers if we start using FIT in isolation as a diagnostic test. And currently in Wales, in the NG12 criteria from NICE still apply, and we still need to consider these patients as being on the suspected cancer pathway. A FIT, however, may help us considerably as a triage tool at the point of referral, so that when we do the overall assessment, this may help us to guide our investigations and prioritize management. In brief, this is the algorithm or pathway for the low risk or DG30 stream in primary care. And I'll consider rectal bleeding separately. But apart from that, as you can see, if you have a low GI symptoms that don't come in the alarm category and a positive FIT, then certainly that needs referral and to be treated as an upgraded USC type referral. Whereas if the FIT is negative, but you're anemic or there's abdominal pain, these are areas where you may get a false negative FIT, and again, there is sense in referral there. However, if the symptoms are those of diarrhea with a negative FIT, then clearly we have other stool biomarkers and other tests that we use in gastroenterology for investigation of diarrhea, which are the sensible way to go. And similarly, if there is a good safety net in primary care, then we suggest a 4-week review with further investigations at the end if necessary. In terms of the 2-week wait or USC pathway, the important thing here is that FIT will determine the triage as to how we undertake a USC triage colonoscopy or not, or whether we choose an alternative form of investigation or management for the patient. And in terms of rectal bleeding, this is an area where evidence is still emerging. We have a couple of very good studies that have looked into it. And though FIT over 10 is quite likely to be the case in anyone with colorectal cancer with rectal bleeding, this is not foolproof. And there are false negatives in this cohort. And therefore, the clinician's decision-making still remains most appropriate in this setting. The safety net systems that we suggest in the primary care setting, and these are not a comprehensive list, but iron deficiency anemia, abdominal or rectal mass, these patients should not wait for a FIT result, and they should be referred as suspected cancer. Rectal examination should be part of the standard care. And any obstructive type abdominal pain should be managed as suspected cancer and referred straight to test, even if the FIT level is below threshold, as this is again a group where we might get false negative FIT results. Similarly, we suggest that if these patients are being safety netted in primary care, then not to leave more than 4 weeks for review. And at that 4-week interval, consider repeating full blood count or FIT result, although evidence in this area still remains emerging or weak. What about secondary care? This follows on logically, and the same things apply in terms of iron deficiency anemia, abdominal pain, where we might get false negative, and we already have established pathways that you can see on the right for patients in this group. And there are areas where we might need to individualize our management where there is no anemia or abdominal pain, but persistent or worsening symptoms where we have to err on the side of investigation and referral. In terms of the USC pathway, again, similar established pathways for suspected or confirmed colorectal cancer, which are already in place if you have a FIT of 10 or more. And if it is less than that, then the other options we suggest are, rather than just discharging back to primary care in this USC group, to consider other options such as either seeing the patient in clinic, or if considered appropriate based on the symptoms, a CT scan, or other suspected cancer investigations in an individualized manner as appropriate. But most importantly, also to communicate that detailed specific plan of management to colleagues in primary care and also to the patient. Again, safety net systems in secondary care have been particularly used during the pandemic. And apart from senior triage, which seems to be very helpful, the other options to be considered are alternative routes of consultation, as we've just discussed, secondary care consultations or rapid diagnostic centers for symptoms, particularly defined as the vague or undefined symptom pathway. Rectal bleeding should be considered for suspected flexible sigmoidoscopy, for USC flexible sigmoidoscopy or colonoscopy, if considered appropriate by a senior clinician, even if their FIT value is less than 10, as mentioned before. And the review time points remain similar between primary and secondary care, depending on where good liaison has happened and re-referral thresholds are established for primary care colleagues. If there is variation in the local health board policy with regard to using a higher threshold, then it's important that this is communicated to patients and primary care colleagues. So for example, if you're using a threshold of 100 instead of a threshold of 10 micrograms per gram of feces, then do need to realize the implications of this, and the safety netting will need to be more rigorous. And lastly, we should not ignore the gut instinct of primary care colleagues and secondary care teams, which is why this should be used only as part of a comprehensive clinical investigation or management. A few things to talk about in terms of thresholds. You can see here some data from the NICE-FIT study, and there are several views on using a lower threshold. Clearly what you can see here, and this differs slightly from the Oxford Brian Nicholson data, roughly to find a cancer or numbers needed to scope with a threshold of 10 micrograms per gram. In this study, you needed just over 6 colonoscopies, whereas in the Oxford study, it was around 10. But if you drop the threshold any lower, it doesn't, you still need to you have far more colonoscopies to find that same cancer. So it becomes a law of diminishing returns, and the negative predictive value does not really change very much between a threshold of 10 or lower. To put it in a different way, if we continue using the same USC pathway that we are currently and don't change this, we need around 30 colonoscopies to detect a single colorectal cancer. If we use a FIT threshold of 150, as we do in the screening program in Wales, we need just over 3 colonoscopies to detect a single colorectal cancer. With 10, as mentioned before, it's just over 6. If we drop this to the limit of detection, which is 2 micrograms per gram, then it needs almost double the number of colonoscopies as we would, at a threshold of 10. So this just summarizes what I've just said. And we just need to remember the last point here, that FIT has a much lower sensitivity for other significant bowel pathology, such as adenomas and inflammatory bowel disease, and even at the lowest threshold is likely to miss such pathology, which can be clinically relevant. The impact on the service has been different in different settings, and this is still emerging. When used in primary care in Scotland, referrals reduced by about 15%. When it accompanied referral in Nottingham and was tilted towards secondary care use more, there wasn't any particular long-term reduction in the 2-week wait colonoscopy usage, but this may have been due to a referral of a wider, lower risk group of patients. And here's some data on rectal bleeding, essentially just emphasizing what I've mentioned before. This is Scottish data, and there are other studies, including the NICE-FIT data on rectal bleeding, which give somewhat similar results in that there is a miss rate for FIT in cases with rectal bleeding. But in the Scottish data, most of these, the single missed colorectal cancer and the adenomas and IBD, could have been detected at flexible sigmoidoscopy. We've, however, kept it flexible and mentioned that the clinician's decision can be sigmoidoscopy or colonoscopy. This just emphasizes that fact. And so finally, people who are not felt to be appropriate for further investigation in secondary care should only be discharged back to primary care with a letter outlining the plan of action. So communication needs to be very good. If there is variation in threshold, then health boards need to consider the implications of this. And we do need to respect the gut instinct for colleagues and clinician decision-making in using FIT as part of a comprehensive management. Thank you for your attention. The way the session is structured, we will move straight on to the next lecture and have the discussion for all 3 talks at the end. It's a great pleasure to introduce my friend and colleague, Professor Mark McAlinden, who's at the Hallamshire in Sheffield and well known to many of us. Mark is a leading light in many things gastroenterological and particularly capsule endoscopy, including some really nifty work that he's been doing on magnetic imaging steering. And I can't think of anyone better to speak on colon capsule endoscopy with regard to the developments in England. So thank you, Mark.
Thank you very much. My name is Mark McAlinden. I'm a gastroenterologist in Sheffield, and I'm going to talk about colon capsule endoscopy I'm going to present a little bit of the background data and talk about the NHS England pilot for colon capsule endoscopy that's been rolled out as we speak. Now, when small bowel capsule came out about 20 years ago, it did well in terms of establishing it as a first-line tool. And the fact that it's a 1 centimeter diameter device lent itself very well to the small bowel because it's small in diameter. But of course, the difficulty with the colon is that it's a voluminous organ and it has haustral folds. And so adapting it proved, to make it a useful tool, proved more difficult. And this was dealt with, first of all, by having a second camera at the other end of the capsule, so that the device could see near 360 degrees, because each lens had a viewing angle of about 172 degrees and it could see behind haustral folds. The data initially, however, was still disappointing in terms of diagnostic sensitivity compared to colonoscopy, but major advances were made with the colon capsule version 2. And perhaps the main reason for this was that it had an increased and adaptive frame rate, such that if the colon capsule fell in the cecum and was more or less stationary for a while, it would drop its frame acquisition rate to about 4 per second. And then when it caught the peristaltic wave, it would increase the frame rate up to 35 frames per second. So this little video shows this quite nicely. It's the same segment of colon seen at 4 frames per second and at 35 frames per second. So you can see that that's likely to make a major difference. Of course, many of you will be thinking, gosh, well, I'm missing behind those haustral folds and this uninflated colon, but remember that there's a second camera providing a simultaneous video in the opposite direction. So here's the data. Here's a second meta-analysis, in fact, looking at the diagnostic accuracy of capsule endoscopy compared to colonoscopy. And I've picked out the data just for polyps of over 9 millimeters, 10 millimeters or more. And the bottom line is that colon capsule has a sensitivity in detecting those polyps of about 88% compared to colonoscopy, which you probably think, well, that's a pretty good tool, might be useful as a kind of second option. Now, what matters to us mainly, I think, is the detection of cancer. Now, although these are only, 6 or 8 studies of 1,500 patients, there's a rather small amount of cancers in those cohorts of patients, or that cohort of patients. And one of the problems, I think, with colon capsule that I think will be addressed is the fact that its battery life is insufficient to allow complete examination in all patients, and the completion rate's variable. In most people's hands, I think it's about 85 or 90%. Nonetheless, a bit less than it is for colonoscopy, or what we would expect of colonoscopy. And that matters because in the 54 cancers that were detected in those 1,500 patients, 10 were missed, and 8 were missed by colon capsule because it did not reach the anorectal verge or exited the patient. And of course, in real life practice, whilst we would hope not to miss these, because we would then look again with flexible sigmoidoscopy or colonoscopy, that defeats the point of having a non-invasive tool that's trying to save unnecessary interventional or conventional endoscopy. Of the 2 others that were missed, one was a reader error and the other was a missized diminutive polyp. This is sized on the computer software system, when in fact the lesion was a 10 millimeter malignant polyp. If we look at the ways in which those studies were included in that meta-analysis, they do comment that according to the QuADAS tool, QuADAS-2 tool, which was used to assess the quality of the studies included in the meta-analysis, many scored a high level of bias. And the reason for that high level of bias was the assumption that colonoscopy was the gold standard. Now, we accept it as a gold standard, but that doesn't mean to say that it's an imperfect tool, or it doesn't mean to say that it's infallible. And if you look at this recent meta-analysis of 10 tandem or back-to-back colonoscopy, this will highlight the importance of that consideration. So I think many of you will be familiar with tandem or back-to-back colonoscopy. These are studies in which patients go into room A and they have colonoscopy by endoscopist A, and then they immediately come out and have a second colonoscopy by endoscopist B in room B, the two being blinded to each other's results. And here's some of the data for all adenomas of all sizes. The polyp miss rate is 29%. For advanced adenomas, so this is lesions of over a centimeter or high-grade dysplasia or villus component, miss rate of about 10%. And if we just look at size of lesion, 10 millimeters or greater, a miss rate of about 9%. So really, it brings it almost to a sort of level of colon capsule versus compared to colonoscopy itself. How does it compare to CT? Well, here's a study of patients in a screening program who are FIT positive, who are randomized either to colon capsule or CT colonography prior to their colonoscopy. And again, if I just select the data for 10 millimeter polyps, the sensitivity of colon capsule at detecting 10 millimeter polyps is 97%, greater than CT colonography at 90%. And if we look at the data in which polyps of all sizes are compared in this study, then it's significantly higher for colon capsule endoscopy, which picks up more small lesions, less than 10 millimeters. And this is a meta-analysis of a number of studies in which patients with incomplete colonoscopy have either colon capsule endoscopy, or in other studies they have CT colonography as the completion imaging tool. Two of them, this was out of about 2024 studies, I think, two of them after incomplete colonoscopy subjected the patients to both colon capsule and CT. Otherwise it was one or the other. And the bottom line was that colon capsule endoscopy picked up 9% of further 9% of polyps of 10 millimeters or more, and CT colonography picked up a further 4% of polyps of the same size. So again, colon capsule endoscopy being at least as sensitive as CT colonography, and taking polyps of all size, colon capsule outperforming CT. This was an interesting study in which 30 patients with sessile lesions of over 20 millimeters, I think it was, planned for endoscopic submucosal dissection, underwent both colon capsule and CT colonography. And the images on the left show the conventional colonoscopy pictures, the ones in the middle, of course, CT colonography, and the ones on right, colon capsule. Colon capsule was picked up more lesions, significantly more lesions than did CT colonography. Part of the reason for this seemed to be that in the uninflated colon, these lesions seem more polypoid than they do with conventional colonoscopy. So many were rather more easy to see. What's the patient's view? Well, this is our study of patients who had optical colonoscopy or CT colonography or colon capsule. So it's an observational study. It wasn't a randomized study. But patients asked to score their overall experience, including that of bowel prep, on a visual analog score. Favored CT colonography, but still the experience of colon capsule was highly significantly better than that for colonoscopy, or those having colonoscopy. So this is what's happening in England. NHS England have published guidelines that those referred on a 2-week wait pathway with a FIT value of over 100 should have urgent colonoscopy because they have a high risk of colon cancer. However, in the FIT 10 to 100 group, who have an intermediate risk, they are recommending prioritized colonoscopy, as soon as you can. And if that cannot be offered in an acceptable time frame, then colonic imaging of some kind, either CT or colon capsule endoscopy. And they've funded £6 million for this pilot, which has been taken up by 43 hospital trusts, who between them will be delivering about 10,000 colon capsules over the next year. And this will be for the fit 10 to 100 age group, fit 10 to 100 level group of patients who are referred on the 2-week wait pathway. And this is their incidence of important organic pathology. So colon cancer about 5%, high-risk adenoma about the same, and IBD about the same. I point this out because, of course, this means that all these patients will need to have colonoscopy thereafter. Got to bear in mind the fact that if we have a 10 to 15% non-completion rate, then similar numbers will have a further conventional endoscopy for that purpose, and maybe another proportion of patients whose PrEP is poor. But this is going to be evaluated in a national project in which we hope to compare the diagnostic accuracy of these 3 modalities in phase 5 of the York Fast Track study. I mentioned PrEP earlier. This is one thing that we can control. Of course, we have the constraints of using this tool in the fit 10 to 100 group, but we may be able to target the use of colon capsule to those who will suit best, I think. And that's patients who are more likely to have a high quality complete examination. So we don't have data that tells us which factors predict incomplete exams, but we do have data from colonoscopy studies about which factors predict poor PrEP with bowel preparation. And those factors are patients with diabetes, cirrhosis, previous stroke, dementia, certain drugs like tricyclics or opioids, and those who have previously tolerated PrEP badly. It makes sense, of course, that those who are unable to comply with verbal and written instructions will likely have a poorer outcome from PrEP. And our nurse specialists remind us that they think that some of our incomplete examinations are because the patient doesn't want to take the Biosecodal suppository. So they not only have to be compliant, but they have to be physically able to administer a suppository at the end of the day if the capsule has not exited the patient, which will happen in about half of the cases. So in summary, I think my view would be that it's a sensitive diagnostic test. There's no described capsule retentions so far. It's acceptable to patients. I think we all view it as a tool to be used in low risk, physically fit and compliant patients in the future. Of course, it's being used in the current NHS England programme to try and mitigate pressures on endoscopy brought about by the COVID pandemic. And that's the end of my presentation. So thank you very much, and I'd happily answer any questions. Thank you.
Thank you very much, Mark, for an absolutely excellent presentation. And we'll move on to our next speaker so that we can have discussion about all the sessions at the end. Before I introduce our next speaker, I'd just like to say to all delegates, please put your questions in the chat bar, in the live chat bar, so that we can pick these up as soon as we enter the discussion section. That would be really good, and we'll try and answer as many as we can. So our next speaker is Professor Angus Watson, who's a consultant colorectal surgeon and has many more hats than that. Also has roles within the NIHR and the lead for R&D for NHS Highland. Angus has really implemented colon capsule across Scotland and a really amazing feat that we hope to learn from. And Angus will be talking about how this has happened and what their results have been in Scotland. So thanks very much, Angus.
My name is Angus Watson, and I am the clinical lead for Scotland's colon capsule endoscopy service. I'm a colorectal surgeon based in Inverness in the Highlands and Islands, and I'm absolutely delighted to be here, and thank you so much for the invitation. So why ScotCap, and where did we start? Well, the demand for optical colonoscopy has always defeated our ability to supply the test, and we needed a response to fill the gap. We were keen on looking at new technology that would help us develop a sustainable and equitable diagnostic service across Scotland. And we started with the end in mind, and that is the provision of a colon capsule endoscopy delivery, reading and reporting service that was integrated into the NHS across Scotland. ScotCap actually started as HiCap in the Highlands and Islands, where we ran a technical feasibility of community delivered colon capsule endoscopy. Patients were referred by their GPs for specialist opinion as usual, and if they were suitable for a colon capsule endoscopy, these tests were delivered in Skye and in Ullapool. The Digital Health and Care Institute is one of Scotland's innovation centres. They have been absolutely pivotal in how we have designed ScotCap. And we are very grateful to the DHI design team, who has done a huge amount of work in engaging with stakeholders and patients, and have really influenced the process that we've taken forward throughout Scotland. They helped with interviews with stakeholders and ran a series of co-design workshops. DHI produced a series of pathways using the information gleaned from the stakeholder interviews and the analysis of those interviews. And ultimately, they've produced an interactive blueprint, which has looked at patient selection, the patient invitation process, what we do before the colon capsule, how we run the colon capsule, what we do after the procedure, and how we report the images and arrange follow-up. Colon capsule endoscopy, as part of the evaluation, was run from 3 health boards. Out west in the Western Isles, in Stornoway, throughout NHS Highland, utilising both community hospitals and GP practices, and in NHS Grampian using a small district general hospital. Alongside running the service, we've conducted an evaluation, and we've used 3 organisations to do this. The University of Aberdeen's CHART unit has been doing the quantitative analysis of the patient outcomes. University of Strathclyde have been doing qualitative work, interviewing patients and stakeholders. And the Scottish Health Technology Group, the Scottish equivalent of NICE, have done cost-benefit economic work. The University of Strathclyde were really listening to the patient voice, both through surveys and through interviews. And the results of those interviews and surveys has really helped us change the process of how we deliver the service. And we continue to collect patient information about their experience through every health board as we run out ScotCap through Scotland. The University of Strathclyde's work was really aimed at identifying the barriers and facilitators of running a colon capsule endoscopy service, considering best practice and prior lessons learned. As I mentioned before, they used interviews and surveys, and then did thematic analysis of the results. They've identified barriers and lessons learned. The principal ones are technical integration and the time it takes, the minefield of information governance, and also the complexity of planning and running the service through multiple health boards. What helped the process was the identification of clinical champions, finding dedicated project management time, and actually running the UK's first health innovation partnership, where we found our service providers, Medtronic and Corporate Health International. The University of Strathclyde produced a best practice checklist, both for the patient journey, but also produced a checklist for the implementers of the service. And we're using this checklist and the DHI blueprint as we engage with different health boards throughout Scotland. We were going to wait for the results of the clinical evaluation and run a business and economic plan on the back of that evaluation, but then COVID hit. So we very quickly pivoted to thinking how we could run ScotCap across Scotland to help us both during the pandemic and to help endoscopy recover from the effect of the virus. We got further Scottish Government funding, which was approved just under a year ago. And we kicked off the implementation planning at really an enhanced pace. And I have to give testament to my colleagues in government and DHI and across the health boards and National Services Scotland, who really worked at huge pace and scale to get ScotCap up and running. We have achieved a number of milestones, which includes very much a once for Scotland approach, so that a bowel preparation is sent out from a central pharmaceutical service based in Tayside to all patients. Bowel preps posted through the post. We have created a single endoscopy management system to facilitate the colon capsule endoscopy service, both the referral of patients, the preparation, bowel preparation prescription, and the report viewing. We've also developed a single suite of patient information materials and an experience questionnaire, which we use in every health board. The ScotCap service has been rolled out in waves. Currently, we have 5 health boards running the service, and we expect all but one of the remaining health boards to have a colon capsule endoscopy service up and running in the next 3 months. The procedure for the capsule was probably going to be different for the island boards, the Western Isles, Orkney and Shetland. And we're looking at how GPs could be the gatekeepers for the process, although the results would still come back to secondary care. This is a really intriguing prospect, and we look forward to discussing this with you and others at a later stage. The adoption of colon capsule endoscopy in Scotland has been complex, and there are a number of lessons learned and lessons we are still learning. We have adopted a once for Scotland approach, trying to get a single service with a single point of information for patients, single bowel prep, a single IG process across the health boards, but this is really difficult. Clinical engagement is patchy, with some colleagues being very enthusiastic and some still being skeptical. Using local clinical champions has been key to help with this process. The co-design and the iterative approach that we are taking is very useful, and we continue to adapt and change how we run the service with time. The research element is absolutely key to this bit of work. So the clinical evaluation continues, and we're about to reveal our quantitative results at the Association of Colour Proctology meeting in July. The results will also be published in a peer-reviewed journal. We're looking at how data and AI can drive our patient selection. We're really interested in the need to follow up small polyps and the risk involved in very small polyps, and how that interacts with the fit testing that we utilize in Scotland in primary care. As mentioned before, we're looking at different models of delivery using GPs as the gatekeepers, and I'm really personally interested in how we can use colon capsule endoscopy to address deprivation and the uptake of diagnostics in deprived groups. Every patient in Scotland has their colon capsule endoscopy outcomes reported in a national registry, and that data is going to be key, particularly when we link to cancer databases and to the Information Services Division in Scotland. We've got a single image repository, so every colon capsule endoscopy image is stored in a data bank, and we're really interested in the provision of new capsules which are on the horizon and new data recorders, and how AI and algorithms can help with the reading and reporting. So I think the future is bright for colon capsule endoscopy, and I look forward to sharing future results with you as they arise. Thank you to you all for listening to me. If you do want to find out more, we have a range of information which we're very happy to share, and indeed have shared already with some of your colleagues. So please don't hesitate to get in contact with us. Thank you once again, and I'm very happy to take any questions.
Thank you very much, Angus, for that excellent talk and amazing implementation that you showed us across Scotland. We were going to go straight into the discussion, but we're going to take a very short break. I would stress very short, just to iron out a technical issue, and we'll be back very shortly so that all our panelists can be present for the discussion. In the meantime, delegates, please put any questions, comments in the chat bar so that we can take those up in discussion. We'll be back. Okay, thank you very much, everyone, for bearing with us with that. Apologies for that minor disruption. I think, I don't know about you, but I was certainly fascinated by both our guest speakers' talks. Really amazing work there, and a lot to learn from. While we're getting some questions in the chat bar, maybe I could just start by asking a bit about the indications that, Mark, you spoke about a little bit for colon capsule, and what we feel are the appropriate groups, because it just seems that one of the things you mentioned were the people who have the poor bowel prep, often with quite a lot of comorbidity, are also the ones who will probably find colonoscopy more onerous as well. And any thoughts that I'd like to ask that to both of you. So perhaps Mark first, and then Angus, what you feel about what the most appropriate indications might be, lower risk or high risk groups, etc.
Yeah, my feeling would be that it's not a test for seeing an older, frail patient with comorbidity, not fit for colonoscopy. That's, to my mind, that's not the indication for these patients, because I think they are more likely to get an incomplete exam or a poor prep and then need colonoscopy. The NHS England pilot is driven by a desire to avoid missing a cancer in the fit 10 to 100 group, who will have cancer in maybe 4 or 5% of cases. So the idea is to pick them up with using the colon capsule and upgrade them to an urgent colonoscopy, if you like. But my feeling is that the fit 10 to 100 group is too high a pathology rate group for it to be used for that purpose in the future, because as well as 4 or 5% having colon cancer, an equal number will have IBD or advanced adenomas. So it seems to me that having to do colonoscopy in 15% because you need biopsy or polypectomy, plus another maybe 10% because of incomplete examinations, and maybe another 5 or 10% because of poor prep, it I think defeats the object of the exercise. And I think the future probably is in the low risk, relatively healthy patients. And when I say low risk, we've got to remember that all the colonoscopies that we do in symptomatic patients, probably 70 or 80% of them have fit levels of 0 or very low levels. So I think it's those that perhaps in the future will be using these non-invasive technologies for. We can provide them with information which tells most of them that they have clean colons, and very few of whom then need to have a second procedure, i.e. colonoscopy for polypectomy or biopsy. Angus, what do you think?
Yeah, we're not far away, Mark, from that. And I guess because we've been in a kind of endoscopy austere time, we have been being a bit more free and easy with the indications for colon capsule, principally because we want our patients to know they haven't got a bowel cancer. And I think, during the pandemic, that's been a real issue, that people have not had that, they've been worrying and sat worrying, waiting on a colonoscopy list. So we're using FIT to triage them. So we're aiming the 10 to 150 group, but we're not being too prescriptive. The different health boards can choose different FIT levels. So some of our colleagues will use upper range of 80 micrograms per gram as their ceiling. But I think we agree it's kind of the low risk group with the lower chance of needing further endoscopy. And that is our target group.
It's still John, it's still you, I think.
Okay, haven't got that green thumbs up yet. Yeah.
Good to go.
Okay, thank you, and sorry about that minor disruption again. I think that's very helpful, actually, from both your experiences in England and Scotland. The other thing I wanted to ask was the issue of quality assurance, and when we have doing this at scale with so many capsules, I think, Mark, it's a good point you made about AI coming and trying to standardize this, reduce reading times, etc. But do we think that we're there yet for implementation with that now, or how did you both manage with the enormous capacity that this is likely to need with regard to reading of the capsules? So perhaps Angus first, and then Mark. Angus?
Thanks, Sunil. So in Scotland, we went down a different route. We have outsourced the management of colon capsule endoscopy. So from the vetting stage, we hand over to Medtronic and Corporate Health International, who essentially are running the service privately, but with some caveats. So the Corporate Health International will run the service. They'll do a pre-test phone call. They will run the test. They will report, although the reporters have to be NHS Scotland-based gastroenterologists, and they're privately contracted to Corporate Health. So that the reports come back into the NHS system here. Mark actually has done some bit of double reporting for us, and there was very few discrepancies. We have a red flag email, so if colleagues come across a colonoscopy finding that wasn't apparent on the CCE, they email the red flag email. and we have a discrepancy meeting, a bit like the radiologists do. We have a discrepancy meeting every month on a Friday, and we go through reports where there is a discrepancy between CCE and colonoscopy. And ultimately, all the patients are going to be entered into the registry, have a national registry, and we're really interested in that polyp and cancer miss rate. So we'll link the registry with ISD, the Information Services Division, and the cancer registries locally. So that's our kind of quality assurance program.
Great, sounds very robust. Mark, any thoughts from the English perspective?
Yeah, our approach has been to get all people who are reading colon and reporting colon capsules to attend, complete, and pass a course run by Image, which is a company set up by Professor Owen Epstein and colleagues in London. It's a fairly rigorous training course. I think it requires 16 to 20 hours, and then there's a summative assessment at the end of the course that everybody has to pass, or whatever the politically correct phrase is. And if they don't, then they have some supportive intervention to get them up to speed. So that's the first stage, and then if there's an evaluation, an ongoing evaluation. So there's an electronic CRF that I mentioned that is to be completed for every patient entering the pilot, and an open forum meeting every 2 weeks online, so that people who are developing, setting up new services and running them can talk to experts about teething problems and questions, and what to do about 4mm polyps, what to do about worries of capsule retention, etc. In fact, I've just finished one of these meetings just before this one. So that's our sort of quality assurance approach.
That's really, really interesting, actually. Thank you. I think it just shows that really needs to underpin anything that we do with regard to implementing these new innovative modalities, that there needs to be a recognition that as things are at the moment, people are not going to suddenly disappear off the waiting list. They will most likely still need colonoscopy, but that there needs to be a robust quality assurance to give confidence in that what's being done actually has got a high exclusion value as well. So that's really helpful. I think the other questions really were around, do you see anything as being relative contraindications to colon capsule other than what you mentioned with regard to someone being too frail or unable to give themselves a suppository? Are there any areas that you wouldn't really venture? So perhaps Mark and then Angus.
Angus might be willing to reveal a bit more information, or maybe he wants to wait until July, but my feeling would be that people need to know that it's not a tool for patients who are unfit for colonoscopy. When I reminded myself of data that predicts incomplete examinations or poor prep, I didn't find anything specifically for colon capsule, but the predictors of poor preparation for colonoscopy, which I think it's fair to assume would be applicable to colon capsule, are patients with diabetes, cirrhosis, previous stroke, dementia, on tricyclics, opioids, or who are unwilling or can't comply with instructions, bowel prep instructions, because the bowel prep instructions, the prep itself isn't that much more intensive. I've had it myself, and it's not that much more intensive, but it's 2 or 3 additional steps. So people have to be willing to do that. And it is an all-day thing, not just like a half-hour, 40-minute test. So they have to be willing. And finally, they have to be sufficiently flexible, mobile, etc., to be able to give them the Bisacodal suppository. So I think it's for people who are going to comply interested in complying, because the difference between poor prep at colonoscopy to poor prep at colon capsule is that colonoscopy, if you're a dedicated colonoscopist, you will wash and suction and change position, so that in some of your patients you'll be able to change what was a poor prep to something that's a reasonably good prep. With colon capsule, you can't do that. So because what you see is what you get. So I think you have to choose patients who are likely to have a good prep. That would be my feeling. But Angus may be able to offer more from his ScotCap experience.
Not greatly, Mark. And I think this is one of the conundrums that we don't adequately know who's going to have a normal and complete test. So a successful normal test. We are actually throwing the machine learning, the AI tools at it at the moment, just to try and do almost a multi-regressional analysis, looking at all the patient factors to see if we can spot particular characteristics of drugs, or age, or sex, or location, which influences successful completion. But I agree with all you've said, Mark, and remember, pacemakers in there as well. We don't do it with the pacemaker. Mobility is interesting because certainly mobility helps colonic motility, and so encouraging patients to keep active once they've got the capsule on board is very useful. And motivation, because the bowel preparation is a gift that keeps giving. So you've had your clean out, and then you've got your boosters, and it keeps giving. So you have to have a well-motivated patient. And I think this might explain some of the completion rates that we see reported in the literature. So Owen Epstein in South London probably has a fairly different population that he's running his colon capsule on compared to the Highlands and Islands of Scotland, or dare I say it, in East Glasgow. And so that the completion rate, which we are seeing, are different in different parts of the country. So a motivated patient is key. And I think that pre-test consultation with the nurse is useful, because it acts as a bit of a filter and makes sure the patient understands what they're getting into, and also the need for a further endoscopy if once they've had the test, whether for poor bowel prep, having expelled the capsule, or there's pathology identified.
Thank you. That's a really fantastic discussion. I wish we could continue further, and we've certainly learned quite a lot. I hope all the delegates also agree. So once again, thank you to both Mark and Angus for giving up the time to be with us today. I'll now hand over to my colleague John Green to introduce the rest of the session. Thanks.
Just check you can hear me okay? You can. I've been on 4 different computers in different rooms and caused mega feedback earlier on, so I do apologise. It was my fault. I'm not Jeff Turner. I'm John Green, Vice President of Wage and Consultant Gastroenterologist. We're just going to hand over very quickly to a very short sponsors break before finishing with some closing words. Just really, it's my opportunity to say some thank yous and just to plan ahead a little bit. So I'd really like to thank Sunil, Mark and Angus for an excellent first Tuesday evening CPD session. As Hayley said at the beginning of the session today, this is something new that we've put together as a Wage lead group, and we hope it is something you'll find of value. We're planning to do one every Tuesday evening, once per month, over the next 12 months, covering a whole diverse topic range in gastroenterology, both medical and surgery. And particularly like to thank Lavanya Shenbagaraj, who's one of our senior gastro registrars, who put together a teaching program for registrars, and we have worked with her to use a similar program for Wage. It's really her idea that seeded this. We obviously have had a few little technical issues this evening, which we need to sort of iron out, and we'll send through the agenda for the other program, other sessions, in the next few weeks. But the plan is to have one on a Tuesday evening at 5 o'clock to cover a range of different subjects. Also to remind you that tomorrow at 2 o'clock we have the second afternoon of the spring meeting. It'll start with Hayley giving us an overview of the plans for WAGE and also summarising the survey that we recently conducted and its results. And then afterwards, there's a really good session on quality assurance in gastroenterology. So thank you for bearing with us, and I do apologise for technical glitches that have happened. And I hope you join us for the rest of these sessions on a Tuesday evening, as well as tomorrow afternoon's WAGE session, which starts at 2 o'clock prompt. Thanks very much, everybody. Bye-bye.